So we're going to talk today about the CMS rule, but this is going to be focused on questions and answers. So after the last presentation, there were a lot of questions that have been posted in the chat box, and then people that registered for this particular webinar also had another opportunity to submit questions. And so it'll be a question and answer format that we'll go through today. So I want to start off with making sure you can see my screen. So y'all can see the screen. So, over the past, 6, 7 years since the rule first came out, I've looked at how things are happening across states. And in the last training that we did, I kind of emphasized you really need to be looking at what's happening in the states. Not that the federal rule isn't important, it is important, but it's how it's being operationalized in states that's where you really need to pay attention to it. So just my perspective on how I see things going in different states. There's some states that I refer to as sleeper states. They're kind of like coasting along, not really paying as much attention. There are some states that I call the confused states because the way that things are being done is not necessarily in line with the CMS rule. And so I call them the confused states. There are some states that are the kind of shock states that almost insulted that you had to have a rule because they felt like they were doing things the right way. And then there's also states that I call the angry states that are really like kind of mad and irritated and aggravated that they're having to implement this federal rule. The problem is that where does that leave all of us when states are all acting differently and in implementing things differently? It really leaves us in a pretty difficult situation. So today we're going to focus on what are some of those differences. Some of them are state specific, but there's also common themes that cross over several states. And so we're going to focus on answering your specific questions. And I grouped the questions into different themes. And the first theme that we're going to talk about is questions related to location and physical characteristics. Now, even though this is not a training, it's more about answering questions, I do have to kind of go over and remind everybody, because everything I'm going to be answering is going to be related to the intent of the CMS rule. So I just want to remind everybody what the intent is. So CMS's goal in implementing the rule is, one, to enhance the quality of home and community-based services. And what that means is that they wanted home and community-based services to look very different than institutional services. They wanted to enhance the quality by making it better than what it is now. And they also wanted to enhance the quality by having some consistencies across waivers and across states, meaning that if somebody transferred from one state to another or moved from one state to another, and they were getting waiver services in one state, that there was some general expectation that they could receive similar services in that same in the next state. The problem is that the way that waivers had been developed up to this point is that states had a lot of flexibility when they developed their waivers. And there were many services that were being provided under the funding stream of home and community-based services, where those services really did look more institutional than looking like home and community-based services. And so they wanted to be able to get some consistency that if you were receiving waiver services in your home, in one state, you didn't move to another state and the waiver service that you would get would be on a large campus that was restricted rights and restricted choices and so forth. And then also part of the rule is to provide protections to ensure that people's rights are not taken away from them just because they're getting Medicaid funded services. So keep that in mind, that is the intent of the rule. The other thing is that, when we talk about institutional services and waiver services, CMS said, we have institutions and we have a funding stream for those institutions and rules and regulations for those institutions. And we have home and community-based services and we have a funding stream for home and community-based services. And those things are not the same and they shouldn't look the same. So first question is, can you clarify whether an HCBS facility can be near a clinic, hospital, or medical center? And is there a specific number of feet or distance that would be needed in order for that to be acceptable? So the answer to that is that, well, first you have to define what do you mean by near, because there are some limits, but in general, CMS does not prohibit home and community-based services from being provided near a clinic, hospital, or medical center. And CMS does not specify any distance requirements at all. So if you are hearing about any distance requirements, those are state-specific requirements. Now, when the rule first came out, CMS was really trying to define what home and community-based services really was so that they could share that information. And so they kind of had to like separate, all right, what really goes into the not home and community-based services bucket, what goes into the presumed not home and community-based services bucket, and what goes into the home and community-based services bucket. And so when you're looking at locations and physical characteristics, what goes into the not home and community-based services bucket, there are only 4 settings that are strictly prohibited by CMS. These are the only 4 settings strictly prohibited. Nursing facility, an institution for mental disease, which is their terminology, an intermediate care facility for individuals with an intellectual and developmental disability, and a hospital. Now, when these are being prohibited from receiving home and community-based services funding, it's not because there's anything wrong with these settings. It's because these settings are already clearly defined in federal regulations. There's already a funding stream for them. They already have rules and regulations, and it operates completely differently than what they want home and community-based services to look like. So what goes into the home and community-based services bucket? Well, you have to keep in mind that the rule is about experiences and it's about outcomes. And actually, when you look at the actual rule, it establishes an outcome-oriented definition for home and community-based services, and it focuses on the nature and quality of a person's experiences, which is about choices, rights, and opportunities for integration. And so if there is a setting that provides choices, ensures people's rights, and provides opportunities for integration, they are operating in a home and community-based services manner and have the characteristics of a home and community-based service setting. Now, the presumed not home and community-based services bucket, and this goes back to what that question was, is can you be near something? Is that there's settings that they are saying have the tendency to be more institutional, and therefore they're presuming that if it's an entity that provides inpatient treatment services on the grounds of or adjacent to a public institution, or as an isolating setting, which we talked about some last time, that those are going to need to be looked at more closely. What's happened though is that there's been lots of misinterpretations across the country, and so it does not mean that these are prohibited. It means that they're going to, just because they have characteristics that look more institutional, until it's determined that they're not institutional, they're going to presume that they are. So it's putting in a, we know clearly these are not home and community-based settings. We know clearly these other ones are, but these fall into the gray area, and these are the ones that need to be checked out. So again, it does not matter. It's about ensuring choices, rights, and opportunities for integration. So what about situations where there's like a fence around the property, or multiple properties on the same street, or houses that are next to each other that are owned by the same provider and agency, or waiver services on the grounds of a private facility? Well, these things are not prohibited by CMS. The confusion comes from guidance that was given where some of the terminology was used. Guidance was given to states, and some of the terminology was used so that the states would pay attention to some of these things. The way that it was interpreted by some states is that these things are prohibited. but they are not prohibited by the CMS rule. Now, a state could impose rules beyond the CMS regulations. And so just because a state is doing it doesn't mean that is in violation of the rule. But it does mean that there may be some advocacy work that you're going to need to do on your part in order to work with the state and maybe change some of the state requirements. Okay, so state requirements, one of the questions that we received is, can you speak to the state's transition plan deadline with CMS? The comment was that I believe the final deadline is March 2022. Is that correct? So here's a snapshot of all of the key dates. The rule was issued in January of 2014, but you had to wait 90 days for it to go into effect. So it went into effect on March 17th of 2014. Originally, states were given 5 years to come into compliance. The first deadline extension was given, and it extended. There was two extensions of this deadline. The first deadline extension was given, and it extended it to March 17th of 2022. But then there was a second deadline extension that was given in July of 2020 as a result of COVID. And the deadline was then extended to March 17th of 2023. However, states don't have to grant people or grant entities that timeline. They can choose to come into compliance whenever they want. And so whatever they share with providers is going to be based on what their deadline is for compliance. So let's say, for example, if a state says and makes a decision that they want to come into compliance by March 17th of 2022, then they may actually even have an earlier deadline for providers so that they can make sure they are checking providers to ensure that they're in compliance even before this particular date. So each state can set their own, and you'll need to check with your state to determine whether they've extended it to the March 2023 or not. So how can you find the state's requirements other than the 1915C waiver? Now, I'm assuming what this question meant was, where do you find what your state is going to require of providers other than looking in the 1915C waiver application? That's how I interpreted this question. So if I didn't interpret it right, you may want to put something in the chat box, and that way I can address it at the end of the presentation. We'll have some opportunities for questions and answers. But answering it the way that I interpreted it, what I encourage people to do is, if you feel like you're not sure what's happening within your particular state, each state agency that's responsible for implementing the settings rule requirements should have a specific web page or website location that you can go to that outlines all of the documents that they're submitting to CMS. You should be able to search for that and go to your state's webpage or website. There's also some other resources that folks have put together. So for example, there's the HCBS Advocacy Coalition. You can access that at hcbsadvocacy.org. They started pulling information from different states, and they have a lot of links on their webpage. And so you can go there and try to find some information about your specific state. And then you also can contact your state Medicaid agency. And the reason I say the state Medicaid agency, each state is structured differently. So some states, you might have a Department of Health, and under that Department of Health, you'll have your state Medicaid agency, your state Office for Citizens with Developmental Disabilities, your state Aging Office. You'll have multiple offices, and they'll all fall under the umbrella of that Department of Health. In other states, you have your state Medicaid agency is in one entity or one department, and you might have your Office for Persons with Disabilities in another department, which has caused a bit of a challenge for states as they move forward and try to implement these rules, because you needed both or multiple departments working together in order to ensure that the rules were that providers came into compliance and the rules were implemented in that state. But ultimately, CMS has made it very clear that the state Medicaid agency, which is the entity that actually receives the funds from CMS, that they are ultimately responsible for ensuring that the state complies with the federal requirements. And so, I would contact the state Medicaid agency to find the information if you're not able to easily find it. Now, you can contact your state's developmental disabilities agency or your state's agency on, home and community-based aging services or home and community-based behavioral services. You can contact those as well, and you can probably get the answer. But ultimately, it's the state Medicaid agency that's responsible for ensuring it. So we had some questions about, we had one main question about resources, and then I think I share resources in other areas as well. But one question was, is there a written resource, either print or electronic, with how others have resolved, like where you need to limit for safety for a few, but keep options for others? So basically, group setting, whether it's a day program or a group residential setting, if there's limits that need to be imposed for some individuals related to keeping them safe, but it doesn't apply to all the others, how do you actually handle that? So there's two resources that I would suggest that you look at. One is, it's a CMS document that's called FAQ concerning Medicaid beneficiaries in HCBS who exhibit unsafe wandering or exit-seeking behavior. And it was published on December 15th, 2016. Now, maybe your issue about safety isn't related to wandering or exit seeking, but I think if you read through this document, you would kind of see the general trends of what CMS's expectations are, and that it would possibly give you some ideas on what you might need, and options for what you can do. And then the other one is a CMS PowerPoint where they talk about risk assessment and mitigation strategies. Now, I do have to say that the PowerPoint's pretty dry for most of it, but there's a small section in there that I think has a couple of good ideas that you may want to refer to. I don't have time to go into all of these now, but I wanted to at least direct you to those particular specific sources. And then following this training, I will go ahead and provide Ashley with a list, with a one-pager of the resources that I referred to in this presentation, so that and the web address, so that you can quickly go to those sources. So then we had a couple of questions about choices. What are some examples of how to provide choice for individuals with severe and profound needs? Now, the thing that I think is most important is exposure. There are people who maybe that do have a preference for something and want to make a choice, but maybe are not able to verbally communicate that. And also what I've seen is that, when somebody has not really been given the option to have choices, they sometimes don't know what the options are. They don't know how to make a choice. And so when you expose people to different things, like different types of music, different types of craft activities, some people like to draw, some people like to paint, sometimes people that paint don't like to, draw with just pencils, So, but until you experience those things, you may not know what you like. And so exposing people to different things is critical in order to support people to have choices. Now, of course, when someone has a severe or profound disability, it makes it more difficult. But I will tell you, some of the DSPs that I've worked with at different provider agencies across the country, some of them are absolutely amazing. And even when working with people that are nonverbal, non-mobile, they can tell you what an individual's preferences are. So, for example, I was working with one agency, and asked the DSPs, what different people in that group liked. And one DSP said, oh, Johnny loves Elvis music. So I asked, how do you know that Johnny loves Elvis music? Well, they tried playing a variety of music, and they noticed that when the Elvis music came on, he seemed to perk up. He seemed to be a lot more alert, paid attention longer, focused on where the music was coming from. And so they know that, and they noticed that difference when they played other type of music, that he didn't do those same things. And so, exposure is important, but watching for individuals' behavior and how they communicate is absolutely critical. I'll share with you another example that I thought was just fantastic of what this DSP did, because nobody asked the DSP to do this, but there was a provider that operated a work-based or facility-based work program. And she had an individual who did not use his voice to communicate, but was very mobile, walked very active. But in previous work programs that he had been in, they indicated that it was a quote unquote problem that he would never sit in his chair, that he always, was getting up and wandering around, and that it caused problems. Now, there could be lots of reasons why he did that. He might not have been interested in the specific work, but so I won't even get into that, but I really like how the DSP addressed the issue. So she noticed that every time that he would walk into the building, he would come in the door and he would stop and he would look around, and then he would walk on and go put his lunch up, and then he would go sit down. And so she noticed that he kept doing the same thing every time he came into the building. He would walk in the door, stop, look around, and then go and start putting his things away. So she tried to find out what it is that he was looking for, or when he came in. What she found out is that he would look around, and once he saw a particular person, which happened to be a female, that's when he would then go put his lunch up and go sit down. Now, she still had the problem with him staying in his chair, but what she decided to do is she asked that young woman if she would be okay with moving her chair next to his chair. She moved that chair. So they moved her over to sit near him, and that reduced the amount of time that he was getting up out of his chair. So, the point of that is that, it really does take paying attention to how people express their interest in something to know what they like and what they don't like. Now, in terms of other choices for people who have severe and profound needs, there may be situations that they are not able to express their choices, or that it may not be appropriate for them to express their choices. And in that situation, you would refer to family members, legal guardians, and others that know that person best and are there to make choices in the best interests of the individual. Other options that I've seen providers do for individuals who have a severe and profound disability are programs that traditionally would operate almost like a school, where they would have set activities each day. They would, maybe they had a sheet that somebody would color, and they would have everybody colored a caterpillar that day, or everybody colored a butterfly that day. You can offer choices as simple as laying out several items and see if somebody wants to just point to something, or that somebody selects something. There's so many ways. I mean, there are so many ways you can give choices to individuals. And so many choices that people make on a daily basis. The options really are huge. I do have some resources on choice making, and I'll make a note to myself to send some resources along on that one pager that I'll share with you guys. So next question was, will the focus on individual employment cut out the employment options for others? So my response is that I do not think it will. Now, will a state choose to? That is possible. But CMS was very clear in saying that their goal was not to eliminate any options, but to increase options. So CMS does not have any goal to do away with group employment. But could a state choose to do that? They could. I think it's important, and we'll talk about advocacy in a little bit, but I think it's very important for people to stay informed on an ongoing basis as to what's happening at the state level. And I think it's important for individuals and families to voice their opinions and preferences, and and for even provider agencies to advocate on behalf of the individuals and the families that they serve and support. And so it's going to be an ongoing issue, but CMS is not requiring any options to be eliminated. So someone made a comment about age appropriate, and the comment was, age appropriate can lead to my 27-year-old son with a love of Sesame Street, et cetera, being shut out of his meaningful joys because he's too old for such. I hope that age appropriate means that the person's inner age choices, not based on others' ideas of what a chronic, is based on a person's inner age choices and not based on what others' ideas of what a chronological age should enjoy. And I did like this. Honestly, nobody dares tell me that my love of PG or G shows is age appropriate. So why judge based on chronological age? And I think that this is an absolutely excellent point. Now, first I want to say, I agree with this. And I agree that if this young man loves Sesame Street, that he should be able to watch what he wants to watch. And no one should tell him that he can't watch it. But not everyone should be required to watch Sesame Street just because this one person loves it. So, and that is what is happening in some places where they think because one person likes something that everybody should like it. I think I talked last time about blanket rules, or blanket policies. Anytime we do anything that's a blanket where it applies to everybody, we should kind of step back and question that, because we are all individuals. I mean, the people on the call today, you might have there might be a bunch of men, a bunch of women, a bunch of younger people, a bunch of older people, but you can't group anybody together and say all these people like that, all the men like golf and all the women like to cook. I mean, you can't group anybody all together and say that they like the same things. And so, but that has happened historically in services for people with disabilities. And so that's what the whole push on age appropriate is really geared towards. It's presuming competent. It's trying to get people to presume competence. And at some point, if you realize what a person's capabilities are, then you can change. But we don't start off thinking that somebody can't. We start off thinking that somebody can until we know otherwise. The flip side of this whole age appropriate discussion is forcing people to learn to do things that we quote unquote expect them to be able to do, like tie your shoes at the age of 50, and we see this happening too. We see programs where people are still learning to add 3 + 3 or still learning to tie their shoes, and they might be 50 years old. And, now if they want to do that, if that's their goal, then that's fine. But I have a lot of shoes in my closet, and I only have one pair that ties, just one. So, I would hate for somebody to force me to learn how to tie my shoes. I could probably do without that one pair, or actually I probably need to be using that one pair more often than I do. But the point is that assuming that anybody should be doing anything isn't appropriate. It needs to be helping people reach their highest potential, but presuming competence. And so that's the point that we need to keep in mind. And that as services are provided, they should be person-centered based on the individual's goals. So then somebody asked the question of what is the CMS definition of a meaningful day? Now, I have not found a clear definition from CMS of meaningful day. That doesn't mean that there isn't one. I just haven't found it. But I will say that based on everything that I have read that comes out from CMS, if I would assume that CMS is going to say that a meaningful day is defined by the person. And then when you look at other information outside of CMS about how you define a meaningful day is defined by doing things that you like to do, being able to make choices, being able to learn, interacting with different people, and having a purpose. And if you think about what makes a meaningful day for you, then chances are if you spent your day doing things that you like to do, having choices and making choices, like where you ate lunch, what you ate for lunch, what time you woke up, what time you went to bed, learning and growing as a person, being able to interact with different people, and then having a purpose, like feeling like what you're doing is that there's value and worth in that in some kind of way, and that that you would probably say that your day was meaningful. And so I think that this is just a really good definition for how we can look at what is a meaningful day for someone. But the bottom line is that meaningful is different to how much time you spend learning versus interacting with other people, or, how much time you spend on these things. And, do you have to do every one of them every day for it to be a meaningful day? No, you don't. It's going to vary from person to person. Now, I do believe that our role in providing services to individuals is to help make a meaningful day for them. And, a person that receives services may only receive services from, let's say, your provider agency for a very short portion of the day. But a day is like 24 hours, right? So maybe they only receive services for a small portion of the day, but that portion of the day that's meaningful for them can be huge. So if you think about your own days, you might have a terrible day at work, but then you get home and, you're happy to see your family. Maybe you go out and do something and celebrate a family event. And that day could wind up being a meaningful day for you, even if the whole work day was cruddy. Likewise, if you flip it, you could have something great happen at work. Maybe you got a promotion, something just awesome happened. And then you go home and your teenagers are bickering. It's terrible. That day can still be counted as a meaningful day for you because something great happened within that day. And so the reason that creating meaningful days are so important is because when we add all of the meaningful days that we have in our life together, and you just add all those days up, and keep in mind, it doesn't have to be all 24 hours that are meaningful. It just has to be a portion of it that's meaningful. But when you add all of those days together, that's what leads to a meaningful life. And I think that if you asked anybody on here, do you want to have a meaningful life? We would all say yes. I mean, I don't know anybody that would say no. We all want a meaningful life. I think that it's more difficult for some people, including people with an intellectual or developmental disability. I think they need supports to have a meaningful life. And that starts with having meaningful days. And so one of the things that people toss around this term about meaningful day, and they use the terminology and sometimes don't understand it. And so I was really glad that this question was asked. But meaningful days are so important to having a meaningful life. And it's important to keep in mind that only a small part of it has to be meaningful, where it really counts as a meaningful day and can add to someone having a meaningful life. The power that we have that providers have is absolutely huge. I mean, if you think about, you have the power to help somebody have a meaningful life. That's just huge. That's just so huge. So next question was on community integration questions. So what examples are there of the community embracing this meaning the community welcoming people with disabilities. And I will tell you this, it is happening. Phenomenal things are happening all across the country, and they are very exciting. Now, we'll say that in places where schools are not as inclusive, I see that there's less inclusion and integration happening in the community and less community acceptance. And I've even had conversations in some states about this, and what some people in the community are thinking is, well, their whole life they grow up and they need to be separated from others to learn. So then that same mindset, they're thinking, oh, well, then they need to be separated from others to work. So that I see a little bit, and that's just my personal observations, that I think it's just more challenging in areas where the schools are less inclusive. But I still see some positive things happening. I want to share with you one example of something great that happened. And this was actually a provider who I had gone and done a training for them and talked to them about how important it was to identify what a person's interests were, and that you don't just bring people, the community integration isn't just about bringing a person to Walmart or bringing them to the museum, that it's about helping them find meaningful connections based on things that are important to them. So I didn't know about this story until about 6 months after it happened, but I had a provider call me and say, hey, I want to just tell you something that happened. So one of the direct support professionals that was working with an individual, the individuals didn't communicate very much verbally, very, very limited in his verbal communication. So he was not going to come out and say, I want to go here, or this is what's important to me, this is what I'm interested in. But what they noticed is that he had this Harley Davidson t-shirt that he wore all the time. And when, like if it was clean, he would put it on, even if he had worn it the day before. And then sometimes even if it was dirty, he would like try to take it out of the dirty clothes so he could put it on. And so they realized that this shirt was really important to them. So there happened to be a Harley Davidson store in their community. And so the worker said, who was responsible for assisting him in purchasing clothes, said, instead of going to like Walmart or the mall, I'm going to take him to the Harley Davidson store. Now, until I heard the story, I didn't even know Harley Davidson sold clothes and other things. I just thought it was just motorcycles. So I learned a lot, but I learned a lot about motorcycles. But so she decided to take him to this Harley Davidson store to see if they could find another Harley Davidson shirt. And they actually, the worker actually took Chris and his girlfriend. So the three of them went to go shopping. When they were going through the store, Chris passed this pair of boots, and he stopped in front of the boots and he was looking at the boots, and the worker said, come on, let's go find you a shirt. And so she kind of redirected him to go find the shirt. And he was looking around and he kind of, meandered back over to the boots, and he was like touching the boots. Like he was like, rubbing the boots. Okay. So he's, pretty much doesn't use words for communication, but he was communicating pretty well right there, that he liked these boots. So the worker looked at the price of the boots. They were really expensive. She told him, she says, that's a lot of money, Chris. If you want, we can try to save some money to buy the boots, but let's go ahead and go and find you a shirt. So they went and looked at a shirt. I think they picked something out. They passed back by the boots to go check out. And he went over to the boots and he picked up the boots and started hugging the boots. Again, he's communicating something pretty strongly here. And so she did have to take him out. And she's like, you really can't afford them today. I will help you save your money for the boots. But he kind of started crying when she took or tearing up when she took the boots away. And so they went up to the register, and the lady behind the register noticed that one of her customers didn't look happy. And so she asked what was wrong. And the DSP kind of explained that, he really explained about the shirt he was always wearing, and explained how she brought him to find something and that he fell in love with these boots. Now, of course, it would have been a great story if she said, oh, we could have the boots, but that didn't happen. What she did say, though, is the woman behind the register happened to be the owner of that Harley Davidson store. And she said, I will sell it to you at cost. And it wasn't because she felt sorry for him. It was because she they shared an interest, they shared a passion. Something that was important to her was important to him. And so what else happened is she said, you know what? She goes, our employees get together once a month, and we have like a employee, barbecue or event, and it's going to be this Saturday coming up, and everybody brings their motorcycles, and you should bring Chris and let him see all the different motorcycles. So the DSP did. She brought Chris over there, and what was really fascinating is that all of the folks knew that Chris didn't communicate with words, but they were all vying for Chris's attention. They were all like, Chris, come on over here, come see my. I also learned that people name their motorcycles. I just didn't know either, but they're like, come on over here, come see my sweet Betty Lou. She is so fun. Look at this. I just had this put on it, and I did this, and then another person saying, oh, forget about that. Come over here and see this one, So they were vying for his attention, but it was not because they felt sorry for him because he had a disability. It was because they had a shared interest. It was because they had a shared passion. And so Chris became part of that, despite the fact that he had a significant disability. Now, is that going to happen in every situation? No, but you don't know what can happen until you connect people with the communities of their interest. And so I use those words very specifically. It's the communities of their interest. Again, community integration and community inclusion, it's not about bringing a person to Walmart or bringing them to the museum. It's about connecting people with others around shared attitudes, interests, goals. We don't go everywhere in the community. We go to the places that we're interested in. And if we go there and we're interested and we have things in common with people there, then that can lead to friendships and connections in other ways. So we had a question about funding. How do providers come into compliance with the HCBS rule without additional funding? So keep in mind that the rule is about choices, rights, which is right to privacy, right to be respected, right to dignity, right to be free from coercion and restraints. And it's also about opportunities for integration. And so choices and respecting people, treating people with dignity and respecting their rights, many of those things don't cost any money at all. Doesn't cost you any money to treat somebody with respect. It doesn't cost you any money to treat somebody in a dignified manner. Now, there may be some things that are needed in order to ensure privacy. And so I do get that, but there are many things that can be done under the rule that don't cost any money at all. And I think that those are really the most important things of this rule. However, yes, money is important for some things. And what I usually tell providers is I said, do everything you can in the rule, do what you can with what you have and do it now. Do what you can. And then when you run into barriers, then you can go to the state and say, we've done these things. And if we had more money, these are the things that we can do. So it gives you a little bit of, it kind of puts you in a situation where you need to partner with the state saying, hey, look, I'm trying to do everything I can. And here's what I need from you in order to do these other things. However, so there's a few things that I want to make sure that you know, because information is power. Under the CMS rule, there were requirements for the state to evaluate everything that they did, evaluate the state's policies and procedures, evaluate the state's rate setting methodology, evaluate how providers are required to bill, evaluate training requirements. The rule isn't just about making providers do such and such. It's also about the state and looking at the state, but no one's ever talking about those things. And so not only are there requirements for the state, which many states have not, I don't think they've done that piece very well, and nobody's looking at it. But in addition to that, CMS offered additional guidance to states on how they can assure integration. And it reinforces that they need to be looking at those things, looking at the rates, looking at the policies and procedures. Many times what limits a person's choices and limits their opportunities, it's not a building, Like there's been so much focus on a building. And is this building okay? Is this building not okay? Is this building far enough apart? That is not what limits people's choices, violates their rights, or limits their opportunities for integration a lot of the times. It is the policies and the procedures, the funding mechanisms, the training requirements. It's those things that oftentimes limit somebody's choices, rights, and opportunities for integration. And so CMS has been, in the original rule and with guidance, stressing to states to evaluate what they're doing with their policies and procedures and billing to make sure that those are not barriers to compliance with the rule. In addition to that, CMS requires states to review their service payment methodologies and rates at a minimum of every 5 years to ensure that there's an adequate provider base qualified to deliver services. Now, there is a problem with that. Sounds great. There is a problem here, and that is that how they usually look at it is they look at how many providers did we have before, last year, 5 years ago. How many providers do we have now? And if there's not a significant number of providers that have gone out of business, then they think, oh, well, the rate's okay. And that's not the case. And so it is, it's important to maintain ongoing communications with the state agency to ensure that when they do review the waiver service payment methodologies, that it's a good methodology, that it is being adjusted based on increasing costs, and that providers have what they need in order to provide good quality services. And then there was another CMS PowerPoint that was done in September of 2021. It was a training for states that did talk about the waiver payments and financing trends. And that's another good resource. So if you are in a position where you are going to be working with your state working to try and make sure your state is looking at those methodologies, you may want to take a look at that specific training that CMS did. And I'll include that in the list of resources when I send it to Ashley. So what about residential settings? Do you believe that CMS rules require New Jersey Supports Program recipients to live in separate homes or apartments from CCP recipients? And why does the DDD take this position? Now, I'm not familiar with even though waivers are in every state, and even though you can have similar service definitions, states can tweak things a little bit differently. And so I'm not familiar with the specifics of this particular state and CCP services. However, what I can tell you is that I haven't seen any rules or regulations that come from CMS that prohibit any person receiving services from living with another person that receives any other type of Medicaid funded services. I haven't seen that from CMS. In terms of why does DDD take this position, I think that's a very fair question to ask them, but I don't know the answer to that. But it's not being prohibited by CMS. But I would ask if I was you. Is grandfathering of existing community living facilities a viable option going forward? Now, again, people use different terminology. And so I'm assuming that when you're talking about a community living facility, that it is a group structure, residential program that has more than one person with a developmental disability or intellectual disability in that residential setting. So that's my assumption. If I'm wrong, please put it in the chat box and then I can clarify and provide you a better answer. So my answer to this is no, there will not be any grandfathering for any services that receive home and community-based services. There will be no grandfathering. But you have to remember, the reason why I'm saying that there's not going to be any grandfathering is because CMS, it's not that CMS is trying to do away with any service option. What they're trying to do is they're trying to say, we have institutions and we have home and community-based services, and these two things are not the same. And so they're trying to make sure that all services are put in the appropriate bucket. And so early on in some guidance that CMS gave to states, they said, when they were asked, the question was asked of CMS, are you trying to do away with any congregate settings? And CMS said no. But what CMS said is that if it's a setting that operates more like an institutional setting, then it just needs to be funded with more of an institutional pot of money and licensed as more of an institutional pot of institutional regulations. If it's going to be operating like home and community-based services and if it's going to be funded with home and community-based services, it needs to operate like home and community-based services. So again, they're trying to figure out what goes into each bucket. And so if it's operating like a facility, like an institution, and it limits choices, if people don't have all their rights, if they don't have opportunities for integration, then it is not home and community-based services and needs to be licensed or certified and paid for differently. So I don't see any grandfathering in. These were some follow-up questions related to these community living facilities. How much of the decisions depend on policies and state Medicaid agencies? How much is driven by federal government? How much is driven by outside stakeholders? Well, I'll tell you this. There's no state agency that sits around and says, maybe that's not true. In general, they don't sit around and say, let's come up with a new policy. There's always something that pushes them to come up with some type of a policy. A lot of the CMS rules and the direction that the federal government went into for home and community services was driven by people who were in more like institutional settings, but really were very high functioning and didn't want to color a picture of Hello Kitty or didn't want to watch Sesame Street. They had other interests, but they were lumped in with other people and presumed not competent. And so CMS, when they started looking at all of the services that were being provided under home and community-based services, they said, we need to make sure that people's rights are not taken away just because they get Medicaid services, and that we support people to live their highest potential, and that we define home and community-based services differently than those institutional services. And so the policies were really driven by people who wanted something different than what they were getting. And so that's where that push came from. And the reason that that's important is because right now, I think a lot of people are thinking, oh, the federal government did this and we have no power and that this is the way they're going and we can't change it. No, that's not true. The voice of the people is huge in impacting the direction. So how much is driven by the federal government? I think that what's coming out of the federal government has been driven by what people were wanting, and to move away from that one size fits all. And so it was driven by stakeholders. Then the federal government drove it. Now states are kind of driving it. And so I do think that at some point states will then come up with policies based on how they interpret things. And that's somewhat of a challenge. And that's why you're seeing some different things across states. But it all started with the voice of the people. And that's what's going to have the most power to make any changes moving forward. And then how often are settings reviewed? The state agencies are required to provide assurances to the federal government, and they write those into their waiver applications. I don't know for sure. I haven't seen any requirements by CMS as to how often these settings need to be reviewed, but I do know that states are required to give those assurances to CMS in a plan to make sure that settings are all operating in compliance with the rule. So will the settings rule make it easier for nonprofits to own real estate that can house adults with an intellectual and developmental disability? So the rule has nothing to do with whether or not a nonprofit or for-profit owns any real estate at all. So the rule doesn't have anything to do with that. You can actually own something. There could be a a provider owned, but then there's also something that's called a provider controlled, where the provider controls that. So it could be that the provider actually leases a house or multiple houses in order to provide housing options for individuals. And so they may be leasing it, but then they still are controlling it. And so, so the rule has nothing to do with owning it. And whether it would make it easier or more difficult, I can't answer. The CMS requirements do have additional requirements for provider owned or controlled settings, and I'll address that in just a minute. But regardless of who owns it, whether it's being leased, what CMS is going to be looking for, and what CMS is requiring states to look for, is how are services delivered in wherever they're delivered. So even if they are delivered, even if you have in your state some states have like community day programs, they'll have a situation where somebody actually goes to a place in the community and never, ever, ever goes to a provider's facility or building. Wherever those Medicaid services are provided, if they are provided at a museum on Monday and at the person's place of employment on Tuesday and at the family's home on Wednesday, wherever those services are provided, people need to have choices. They need to make sure that their rights are intact, that their rights have not been removed, and that they have opportunities for integration. So it doesn't matter about the building, it matters how those services are provided. So what does CMS say about the consolidate waiver participants and their needs not being met? The comment was families and individuals are paying for services that are waiver services in order to receive the much needed services. And that the problem is that there's either no service providers or the service rates are too low. So there's a kind of a lot that's in here. One is that states are required to ensure health and safety. They are required to ensure an adequate network of providers. So if you're having difficulty finding a provider for a service, that is a state's responsibility. It should be brought up with the state because that is something that CMS actually looks at states for, and they do take that very seriously. And then talk about the service rates too low, which are contributing to the no service providers or high turnover of staff and so forth. Again, it goes back to a couple of slides ago that I mentioned, is that that CMS does tell states they're supposed to be looking at what's keeping people from being in compliance with the rule. But in this situation, what's keeping them from services being delivered at all? And so this is an even bigger issue that that would require some advocacy efforts on your part with the state. So what about residential settings? Many limitations have been set on the number of residents and proximity to other group homes. I've already said that there's no CMS requirement on proximity to from one home to the other. And there's also no CMS requirement on the number of people that can reside in any one location. Now, like any one home. Many states have implemented rules that say, okay, no more than 4 individuals. There are some states that have local zoning requirements that say, no homes in this area can house more than X number of unrelated people. So there's other rules at the federal level, state level, and even local level that could influence what your options are in terms of the number of residents. But in terms of the CMS rules, they do not limit the number. Now, this is another situation where I would suggest that you have communications with the state to find out, why was a particular number chosen, why 4, but there are states that still are operating and are planning to continue to operate with as many that I've seen, as many as 8 that are funded under home and community-based services. The ones that I've worked with that were more than 8 were licensed differently and were not licensed as home and community-based services. So another question about my daughter's day program, pre-vocational services and specialized habilitation is under heightened scrutiny. The state appears to be misinterpreting parts of the settings rule. They seem to want to change pre-voc services to competitive integrated employment. And is there a way to raise concerns to CMS? So there's 2 issues here. One is that they seem to want to change pre-voc services to competitive integrated employment. Let me address that part first. So there is a big push across the country for employment first, which is competitive integrated employment. Let me just remind people that is employment first. It's not employment only. Competitive integrated employment and the whole employment first is really to try to push people's mindset to presume competence and push people to try and support a person to reach their highest potential. Now, does that mean that everybody's going to reach their highest potential? No. But if somebody has the potential to be in competitive integrated employment, why would we ever want to deny that to that person? I mean, we would never want to deny that to the person. I wouldn't want anybody to deny that to me. And so we want to try and like shoot for the moon. And I'm sure you probably heard that saying, you know, shoot for the moon. And even if you miss, you might just find yourself among the stars. So shoot for as high as you can. And I do support that 100%. But I also recognize that there is a wide spectrum of needs and that one size does not fit all. But I want everybody to reach their highest potential based on what's important to them in their life. And I would assume that if asked that question directly, that you would all say the same thing. And so in terms of changing the pre-voc services to competitive integrated employment, one of the things that has been done is that CMS has imposed some time limits on pre-voc services. And it's not to deny people a service, but it's because they're trying to get all these definitions right. You know, you can't give just like you can't, you know, if you're on a campus with 150 people and everybody receives all their services there and everybody's told what time to eat and what time to go to bed and what time to wake up and what work they do, that's just not home and community services. It will never meet that definition of home and community services. It meets the definition of an institution. So that same logic can be applied to employment. You know, employment is typically defined as competitive integrated employment at minimum wage or above. But yes, people work and earn money in many different ways. But the purpose of pre-voc is to support a person to be able to gain employment with the highest goal being competitive integrated employment. What has happened historically is, and this is all across the country, is that people were put into pre-voc services to earn some money and to learn some skills, but there was never any goal to move beyond that. So what was happening is that people were being stuck in programs, but we weren't really focused on supporting a person to reach their highest potential. And people were getting stuck in programs. And so the mindset, and this is my assumption, the mindset was, all right, if somebody is going to be going to work, it probably should take no more than this amount of time in order for people to be able to move to another phase of employment. And so that's why they're limiting the pre-voc. And what the thought or the logic is that if they're not able to achieve employment and move out of those pre-voc services in a certain amount of time, then let's find what is best for that individual. Because if that employment goal is not attainable or is not what the person wants, let's find what is attainable and what the person does want and define, and that might be defined differently. So I don't think that they're trying to change pre-voc services, although I know that there are some folks some agencies that are, some states, that really are limiting some options for folks. That is not coming from CMS. One thing that also is kind of confusing related to what all's happening around employment is that when the CMS rule first came out, there was some other federal legislation that also came out around that same time that was focused on services for people with disabilities through your vocational rehabilitation system. And so that's kind of been confusing as states were trying to manage what the U.S. Department of Labor's requirements were under the Workforce Innovations and Opportunities Act, and what CMS's HCBS Settings Rule requirements were under CMS. So then the next question is there a way to raise concerns to CMS? Yes, there is. And throughout the whole process, once the rule was issued, CMS on numerous occasions has enforced to states and made it very clear that public input and stakeholder input is critical, not just at the very beginning, but all throughout the process. And ongoing. I mean, like even after March of 2023, stakeholder input is important. But CMS has also made it very clear that they want people to work with the states before they come to CMS. And that if you go to CMS with a complaint or an issue, one of the first questions that they will ask is, have you discussed this with the state? So keep that in mind there. On congregate residential settings, if the setting is multiple homes that the families privately own and the families want their special one living there, is that okay? And it would seem like it would be violating their civil rights for them to try and say no. So again, CMS does not prohibit congregate settings. Individuals do have a choice of where they live. And regardless of where they live, if HCBS services are being provided, it must be in compliance with the rule, must provide choices, must ensure rights, must provide opportunities for integration. So can you talk a little bit more about residential constraints due to the HCBS Settings Rule? And can you talk a little bit more about supportive housing and certified settings? Now, again, I'm not sure what state this is from. And so supportive housing can be defined differently in different states. So I'm assuming that it's related to this first question. So I kind of lumped these two together. So just to give a kind of an overview on the provider owned and controlled settings, this is like a checklist that if you own or control the place where a person lives, the things that you need to make sure that are in place is that you have a legally enforceable agreement, that people have the same eviction protections that they would have, that anybody else would have, that they have the right to privacy in their living quarters, in their room, that they can have locks on their doors, that they have free access to areas of the home. And free access also means that the home is accessible to the person as well. And then access to food, meals, and storage of food. And then also that they can choose their roommates and who they live with, that they can select the furnishings, that they have control over their schedules, that they can have visitors whenever they want, and that the home is accessible. Now, of course, every time we go over this list, there's providers that always say, what about so-and-so? What about so-and-so? What about so-and-so? There are exceptions for some individuals. Again, one size never fits all. But what the rule needs to accomplish is that we don't hold everyone or prohibit everyone from having privacy or locks on their doors because of one person that can't have locks on their doors. So one question that I get a lot is about people that maybe have some restrictions on eating. So can you have restrictions there? And yes, there can be modifications to the setting requirements, and so additional restrictions, but it must meet certain criteria through CMS. And this applies to any restrictions, like if you're limiting food, if you're restricting visitors, if you're restricting any furnishings, anything that you are restricting, there's certain requirements that must be met before those restrictions can be put into place. Now, I don't go into here the process for all of that, but it is outlined by CMS, and I'll try to include a link to that on those restrictions process. But one example that I want to share actually came from one of you guys. And so one of you mentioned in my son's house, the kitchen needs to be locked because of one of his housemates. I, as his guardian, had to sign off that it was okay. that this is done. The staff know my son and the other housemate can come into the kitchen. The staff know that my son and the other housemates can come into the kitchen, and so they allow this. So they've worked something out to make sure that they aren't denying people their rights to free access to the food, but they've explained to them what the process was going to be and whether they were okay with it. And then they've provided a means to access the food when they, through the staff, but they know that can be done. And that was worked out and agreed to by the people that live in that home. Okay, advocacy. So there's several areas that I'm not going to address each one of these specifically because they all relate to what my recommendations will be in regards to advocacy. So one was Pennsylvania is restricting the use of services. How do we get them in compliance? We would love to hear any advice about how to challenge these restrictions on size and density of settings. How can it be legal for states to impose rules that are more restrictive in nature than the federal regulations? And what can be done about realigning state regulations? And then please address the New York state regs. They're super restrictive and we need some guidance. So first thing, it's good that you're on this webinar because the most important thing is to know your facts. Know what is a CMS requirement versus not a CMS requirement and that it's being imposed by the state. It's also important to know that why some of these things were pushed. Why are they pushing to, allow, people to have access to food or visitors, that for so long rights were taken away from people. And we're trying to make sure that doesn't happen. So know the facts. And then the next thing is educate and advocate. And here's another great statement that came from one of you guys. In Missouri, we've been involved with the state people directing the final settings rule. They've been very open to our opinion. It's really important to keep your senators, representatives, and state employees up to date. Advocacy is so important. And it absolutely is. If you are in a situation where you feel like you can't really advocate on your own, it's very important to join a state level group that you can work with. That could be a state level trade association, a state level advocacy organization. If you are an individual that receives services or a family member, there are family groups that can be formed. You can join, bring up the issues in a developmental disabilities council meeting. In every state, there's some things that are good and some things that are not good. In some states, DD councils are fantastic. Other states, not so much. But the same thing for other advocacy type groups. In some states, they're great. In other states, not so much. And so see if you can find, one of those advocacy organizations that you can work with to pull people together to educate and advocate for what's needed. Someone made a comment about sometimes the state has agencies that work for the state in some way, and the state only receives or accepts their information in order to make decisions. And community, families, and individuals are not being a part, only those that are connected with the state. That does happen. I mean, that actually happens in my state. But part of it is because you'll have, like, let's say even an advocacy organization, it'll be based on who goes to those meetings, who shows up, what voice is being heard, and then they might take that information and then they'll use that information to then bring it to the state. And so if they're not hearing your voice, then they don't have that information to use to advocate for the state. So very important there. If you don't find a group that you feel like you can join to help you advocate at the state level, I would suggest that you create one to do that. But your voice doesn't matter. I shared earlier CMS has talked about public input. I want to just point out that very early on, CMS did present at the HCBS conference. That was in September of 2015. And they said states should ensure continued public input on assessment results and implications throughout the process. In addition, CMS has given ongoing guidance to states on addressing barriers to implementation. And one of the, just as an example, one of the things that they did in a training that they provided to states was they asked the states, does your state support providers to develop a community of practice model where they can share experiences and concerns and to provide a voice with state leadership? So CMS is urging this, and there's several, these are just two examples that I'm pointing out, but CMS is constantly urging states and asking states, what stakeholder input have you done? And not only that, when the rule first came out and states were required to do some initial public, receive public input, not only were they required to receive public input, but in the responses from CMS back to states had to defend, what did you do with that input? Why did you accept it and incorporate it into what you're doing, or did you not accept it, and why? So it's not just about running through the checkoff box. Yeah, we did it. We got public input, and then they take all the comments and file it in the drawer. CMS is requiring that states talk about what they actually did with it, the information. So my state is saying that the participant has to be in the community a specific percentage of time. This is contrary to the person planning their day. What suggestions do you have? So this, although this is similar than the ones previously, I separated this one out because it specifically talks about this is contrary to the person and what the person wants. CMS does not require that anyone spend any amount of time anywhere. They specifically say that people need to be provided with opportunities to access the community. And opportunities means the set of circumstances that makes it possible for someone to do something. And so what that means is that what our jobs are in supporting people is to help remove the barriers for people. So create a set of circumstances that makes it possible for someone to do something. So let's say somebody really wants to, go to a local fair that's coming up, but they don't have the money. They don't have transportation. It's like, how can you support that person to save their money? Can you teach them how to save the money and budget and plan? Can you teach them how to learn how to access public transportation if that's available? Can you help facilitate transportation if they don't know how to access public transportation? What is it that you could do to support a person that helps remove those barriers to whatever they want to do? Barriers that you and I may not have, but that barriers that stop them from doing the things that they want to do. And going back to person-centered planning, it is about what is important to the person. And I would absolutely, this is definitely a conversation that I would have with the state to talk about this issue. I think that what states are trying to do, and I do think that this does happen. I've seen this happen where I've had providers tell me, well, so-and-so wants to come here and they don't want to go in the community. Well, the reason that they're saying that is because they ask the person, do you want to come here or do you want to go in the community? Well, if they don't know what community means, they're going to say, I want to come here. Like, and I would too. So it's a lot of times it's about people may not understand what their options are and have never had the experience to experience things differently. And so that goes back to the whole exposing people to different things so they can learn about different options. But at the end of the day, it boils down to, is the person making informed choices and they need to be spending the day in a way that's meaningful for them based on what their person-centered plan says. And that is what is most important. So are there trainings available for families and beneficiaries? There should be. The first thing that I would recommend is check your state's HCBS webpage. Sometimes they will have trainings that are announced there, or they'll actually have any training that was previously done recorded and posted. Sometimes they'll have just PowerPoint. I would suggest that you go and look there. I will say, however, a lot of the trainings that I've seen that have been posted by states have been very generic, like the rule says, but without a whole lot of explanation. And so it's really kind of hard for people to take that information and understand, what does that really mean for me? What does it really mean for my family member? And so that is a little bit of a challenge, but I would go check there to see what's on the your state's page. And then I would look to other statewide advocacy entities different states call them different things. Could be your DD council. It could be the governor's council on disability. It could be a state chapter of the ARC. But it could be some other state level advocacy group. They may be providing training for individuals and families. So I would check with them to see if they put anything out. And again, not that HCBS Advocacy Coalition is the only thing. I'm not promoting them necessarily. It's just that they do have a lot of information on their website. And so that is one place. They do have some videos recorded. And then there's also, I didn't mention it here, but you can Google on YouTube and you can search on YouTube and look for trainings that are for individuals and families as well. So I would look there. And then the last few miscellaneous questions. What about individuals with lots of abilities in terms of employment, but due to autism have some concerning behavior? Again, I want to emphasize that, and I'm assuming that this is related to competitive integrated employment and maybe that not being an option for this individual. If my assumption is wrong, please put it in the chat box and I'll try to answer your question. But CMS has been very clear that they are not eliminating any options. States are, though, and I've seen that. And the CMS rule does allow states to implement more restrictive rules. But when a state imposes those additional rules, they should do so by either changing the regulations or submitting a new waiver application to CMS to revise what how they're doing things. And either way that they do that, those proposed changes should go out for public comments first. So there's opportunities for input. If some change has already been made and already been approved by a waiver application that was submitted, and when I say a waiver application, in order to provide waiver services, a state has to fill out an application, a very detailed application, and submit it to CMS saying, okay, yes, we want to get your portion of the money to provide these services. And this is who we're going to provide it to. This is how we're going to provide it. These are the services that are going to be in there. These are how we're going to do rates. So it outlines everything for how they're going to operate that waiver service. They submit that to CMS and CMS approves that. So when I say waiver application, that's what I mean. So the application can be an approved application. But then if there's changes that need to be made to it, then they have to revise that application or develop a new application to, if it's a new waiver, and then submit that to CMS for approval. It all has to go through public comment, even if the state already received approval and there's a change that's impacting services and it's not what people are wanting, then that's when you need to start advocating again at the state level. But it is the state it's not CMS that's limiting the options. And then this is the last question that we had that I received ahead of time. Is there any advice for participant directed services, which includes the supporting person in the family? My advice is the same for all of the other advice that I've given, is that one, even if people weren't required to comply with the CMS rule, I really do think that all people should be provided with choices, as many choices as they can make, as many choices as they want to make. We get to do that. And I don't know why that should be limited just because somebody has a disability. Doesn't mean that they can make all the choices, doesn't mean that they will. Sometimes they can be supported to make those choices. There's different variations for how those choices are made. But no choices should be taken away from somebody just because they have a disability. That all people should have rights, right to be respected, right to be treated with dignity, right to privacy, right to be free from coercion and restraint. And all people should have opportunities to integrate with the communities of their choosing. And those opportunities mean that we help remove barriers to something that they want to accomplish, the integration with the community that they want to accomplish. And so that's the same regardless of what services are received. But in terms of if there's anything that's limiting for people that are in self-directed services or any type of home and community-based service, it needs, your voice matters, and you need to advocate, know your facts and advocate at the state level. And there's power in numbers by joining with others that share similar views. So that is the end of the questions that I received ahead of time. But I do think that there were some that were posted in the chat box. So we have a few minutes that we can, that I'll address those as well.